Welcome back, everyone, to Rocks for Jocks. My name is Alex, and I'm your host for the show. Today, I'll be talking to my friend, Matt Curran. Matt did his doctorate in physical therapy just a couple of years ago, so I definitely have a fresh face from the field for you all today. We talk about things like how nerves repair themselves, dissecting cadavers in the lab, what it's like working with patients of different age groups, and more. Please subscribe on Spotify, Apple Podcasts, Amazon Music, or YouTube, or wherever else you might be listening. And if you like this episode, please send it to a friend or family member. I love making the show, and the more people listen to every episode gets me even more excited to create the next one. Now kick back and enjoy the show. So you got a doctorate in physical therapy. Yeah, just tell me a little bit more about what that degree is and what it was like to go through that program.
So I got my doctorate in physical therapy from UMass Lowell. I went there for my undergrad as well. And I was fortunate enough in high school to have gotten a direct entry into the graduate program as long as I maintained a certain GPA throughout my undergraduate years. The reason that physical therapy is a doctoral degree now, it actually prior to 2015 was a master's degree, but they made a decision to upgrade it to doctoral status in an attempt to get us more autonomy as a field to be able to accept patients without going to a primary care first and skipping some of those hoops that a lot of patients have to jump through, and they would just be able to access the care they need to be able to help with whatever ailment is going on. So we're trying to make it so that patients have the best opportunity and the best resources available to them.
Cool. Okay. How do you think that transition's gone? Do you think that's been a good shift overall for the field?
Unfortunately, we've definitely hit some hiccups. The American Physical Therapy Association does not have the same power and diplomatic strength that something like the American Medical Association has. As much as we do have the ability for direct access, a lot of times insurance companies are still going to require you to see a primary care physician to get a referral. So we're not quite there yet, but hopefully in the years to come, we can start advocating for ourselves more and getting that autonomy.
Cool. And then going back to graduate school. So tell me a little bit about what your undergrad was like and any prerequisites you definitely had to take.
I mean, most of my undergraduate was pretty basic at a liberal arts school. Once we hit junior year is when we started to ramp up the courses that were specific to gearing you towards an exercise-based career. Because with my undergraduate degree, I got an exercise physiology. You do not have to go into physical therapy. It's a nice stepping stone towards that. But there are people that become exercise physiologists. You can get a master's degree in that as well. That's more of a research side, and they do more clinical trials and things of that nature. But there are now tracks that you can take. They weren't in place when I was in school, but they are now available to gear you more towards a business side versus a physical therapy side versus the exercise physiology side. So the field is taking off, and the schools are really helping grow that field, which is nice. But once we get into graduate school, that's when the rubber kind of meets the road and you get down to business.
Cool. And what was that transition like for you? How much more challenging was graduate school?
Well, I graduated my undergrad degree on a Saturday, and I was back in the classroom on a Monday. And we went year round. We had a month off in August and a month off in January. And those were kind of our two breaks during the year. Otherwise, it was continuous for 2.5 years.
How do you feel about that?
It's quicker, but it certainly doesn't feel that way when you're in the program.
Sure. Yeah.
We have to take courses during the summer. You take the first semester that you're in grad school for physical therapy school. Generally, no matter what program you're in, you're going to take a cadaver anatomy course. And that right there kind of separates a lot of people. It makes you realize, do you really want this? And it is a challenging course because now you're not only reading and memorizing from a book, this is what this muscle does, this is what nerve innervates that muscle, but it's now recognizing that muscle on everyone's unique human body. And it's something special to be able to actually hold a muscle in your hand and pull on it and realize this is what's causing the action. When a muscle contracts, we see a certain type of movement. And so you can pull on that muscle and cause that contraction and cause movement.
Yeah, I remember we did, I don't know if you call them cadavers or not, but we definitely did dissections of other animals in high school biology class. For example, they bring in a chicken and you start with something small like a chicken. Everyone's, not everyone, a lot of people have eaten chicken before, not that big of a deal. And then they move on to a rat or a frog. In some cases, my fiance, I think one time had to dissect a cat in high school.
Oh my goodness.
Um, yeah. Yeah, I guess just kind of curious to hear more. How'd you feel about that with the cadavers?
At first, it does, you don't want to take that class directly before lunch, but being in there all summer, working on the same body the whole summer, we were privileged enough to have three cadavers that were donated to us. And so, in most physical therapy programs, there's a medical school associated with it, and they will do the dissections. However, we don't have an associated school. So, we were the ones performing the dissections using the scalpels, using the bone saw to cut open the chest plate and be able to access the heart, the lungs. It was a very unique experience. And I know it sounds crazy, but it was probably my favorite class in grad school.
Wow, that's intense.
Yeah,
I had my friend Aiden, who's in medical school right now. I just had him on for an episode as well. And he similarly had just taken a class on opening up cadavers and he said the same thing, just like totally honored, loved doing it, and really got a lot of goodwill towards the medical community out of that process.
100%. And you also get to see, I remember there's two unique experiences during that class. We're able to see anomalies, medical anomalies in some of these patients that they live with their entire lives. They never knew they had something that was considered abnormal. But,
Huh.
because we were able to open them up, we saw that one person had an extra muscle in their leg. Our teacher, she was constantly quizzing us, pulling out a muscle and saying, "What is this?" And nobody in the class could answer. We were giving out wrong answers. And then she goes, "I don't know either because it doesn't belong here."
Oh my
So,
God.
yeah, that was pretty unique. And then somebody actually had an extra bifurcation, an extra artery coming off of their heart.
How does that work? What does that do?
Well, normally you have three branches coming off of the heart, and this person had four. It's just a difference in the blood supply, but person probably had no idea ever that they had this anomaly.
So I guess then after after that class, what else did you guys study there? What else did you work on? What were your favorite classes?
We had to take a bunch of different courses that related to your movement. So they broke that down into lower body, upper body, and then kind of a combined overall anatomy course. We one, two, and three. But we also took neuro, and our program was heavily based on neuro foundation because we had one of our former professors. I was not fortunate enough to study under her, but she wrote essentially the book on neurophysical therapy. And she taught my then neuro professor and passed along all of her wisdom to her. But it was a very challenging experience, especially going through that during COVID. So I was isolated
Mm,
to my apartment or coming in for weekly labs, hardly seeing a lot of my classmates.
okay. And then when you say neuro, are you saying like neurological system, like signals going from the brain to the muscles, that kind of thing?
Sure, it involved both learning about the role that the brain plays in moving and controlling our body, as well as learning about the different dysfunctions that can happen when
Mm.
we have a stroke or we develop muscular sclerosis or have a spinal cord injury. And we learn not only the mechanism of how this happens and what is going on during that process, but also how can we physically benefit these people to teach them how to cope with their new life.
What was something important you took away from that step of schooling?
It really humbles you. I've had the pleasure to work with a lot of differently abled people who have had, spinal cord injury, strokes, other traumatic brain injuries, and there is no cookie cutter textbook example of how somebody's going to be affected after that event. And makes you realize that how important our profession is in helping these people to develop strategies to live the most independent life that they can. But
Mhm.
it also stresses the importance that you cannot just give everyone the same exercise or the same program to try and get them back to their goals. Like everyone has their own individual goals, everyone has their own experience and what's going to motivate them. And you have to use that to help you and help them.
Cool. That's really powerful stuff. This is almost getting emotional over here. Jeez. And then did you get a chance to do any research in graduate school as well?
I did do some research. Majority of my research was post-stroke neuro-based. So I did a lot of studying of patients post-stroke and analyzing their return to function. It's very imperative that after a stroke, you do depending on the type of stroke, but there are most across the board, you want to do pretty intensive therapy initially because the first 2 years are critical in what you're going to recover and regain ability to do after a stroke.
Really?
Mhm.
Why is that? Can you explain maybe part of that process?
Sure. Our nerve endings. So when somebody has a stroke or they have a spinal cord injury, anything that affects the nerves that innervate our muscles, they are damaged. And our muscles, our joints, our bones, things like that, based in collagen, heal in about 5 to 6 weeks on a healthy adult. So if you break a bone, the doctor is going to say, you're going to be out of commission for 6 weeks. We don't want you putting any stress to that. Let's say you broke your humerus. So we don't want you to put any extra stress to that arm. After 6 weeks, you might get the calf splint, whatever, removed, and then you can start that training to recover with physical therapy. Nerves grow at a much, much slower rate. And it's centimeters per week, month. It really depends. To be able to regrow that full nerve could take up to 2 years. And so we don't fully know what you're going to regain. And some of these therapeutic exercises and motions that we put people through help to trigger the brain. Okay, this is what I used to be able to do. I want to grow a new nerve pathway to be able to do that again. The most fascinating thing I think is in somebody that has had an amputation. I've worked a ton with those patients in the hospital. And you'll always hear about phantom nerve pain, right? And that's a crazy thing. We don't fully understand that. However, part of the information that we do understand about that pain is that when we sever nerves that would go down to, let's say you had a baloney amputation, those nerves that would run to the foot, they still exist up until that point that we've now severed. The brain is still sending signals down there trying to tell the foot, hey, do this or do that, and it doesn't work. So as our brain starts to rewire our legs, and those nerves are still useful, we want to use those for other things, and they might be then converting those nerves over, and if we're using that nerve that used to tell the foot to do something and now it's working on the knee, our brain sometimes gets confused. It thinks that it feels something down at the foot or it causes pain where it doesn't exist. So it's because we're constantly reworking our nervous system after an injury.
Wow, that's freaking crazy. And also, just want to note over here. I don't know if you can tell I'm making some cringing faces. It isn't not that I'm not interested. It is because I am just so weak when it comes to medicine. I could never do what you guys do. So it's more of an appreciation. You should take that as a compliment, not an insult.
Fair enough. Understood.
Cool. And then when it comes to actually regrowing the nerve, what kind of exercises do you give people for that? Is there something you tell them to do, or a way to think about the way that they're doing the exercises that changes the way the nerves themselves act? I just have no idea how that process works.
So, a lot of times when somebody's unable to do something, we have to use many different strategies. But with somebody that's had a stroke, oftentimes we'll use what's called mirror therapy. And so, you will utilize a mirror in front of the patient and show them, have them reenact it with their good limb. Let's say that we're trying to kick our leg out straight. So, they will then utilize the mirror to see, okay, my left leg is going out straight. I want to make my right leg do that too. And sometimes it can help rework the brain to be able to initiate that motion. You're definitely not going to right away, like, oh, I can see the mirror. Now my leg's going to go up. No, it doesn't work that way. But you might be able to start innervating or activating those muscles in the leg that would cause that. So our big quad muscles, you might get a little squeeze there, and we know, okay, that's the start of what we want to do in order to achieve that leg kick out.
Sweet. Okay, thank you.
Mhm.
And then as far as the research goes, what was kind of your role in that? How involved were you with the projects, and I guess how did the results go?
Ours were a little bit more of a review. We collected a lot of data from other studies. We didn't, unfortunately, because of COVID, have the opportunity to complete our own experiments. And sometimes that's very difficult when you're talking about human subjects to allow students to come in and get permission and get approval for that process. So a lot of ours did involve collecting that type of information from previously done studies and compiling the best exercises and programs to help with whatever diagnosis we were studying.
Okay, that makes sense. I mean, that's like a meta-analysis, right? That's
Correct.
still
Yeah, yeah.
that's still super important. But yeah, and also like not your fault that wouldn't let extra students interact with patients like that. Yeah,
Can't
that makes
control
sense.
that.
Yeah. Did your advisors eventually get that stuff published?
We didn't go for publishing, no, unfortunately. We didn't really work with the professors as much on that piece. There were some other students that had connections with their professors that they were putting out information to the public, but ours was more of a internal for our school project.
Sure. And then did you have any clinicals, either, I guess, in graduate school or in undergrad or after school?
Sure.
How'd that process work for you?
Yeah, that was definitely a challenging process. So that first clinical was coming in summer of 2020, right as COVID had started, and I had placement at an outpatient physical therapy clinic in New Hampshire. I remember the weeks prior to, I kept getting emails that kept pushing back the date further and further. And I was lucky enough to still complete a 6-week clinical that first summer. And within physical therapy, you need to compile 30 weeks total over the course of your graduate degree. So originally I was slated for 10 weeks on that first clinical, bumped down to 6. So I was a little behind, but was able to catch back up with the other two clinicals, which I did thoroughly enjoy. I was able to work in Lowell at the VA clinic with veterans, which was a very unique experience working with patients that had encounter Agent Orange and had a lot of these chronic, unexplainable illnesses and pain and things of that nature. But what I will say, working at the VA, you have access to everything because there has been such a strong push to give to our veterans who have served. We had state of the art equipment that we were able to put spinal cord injury patients in overhead treadmills that had robotic legs to help move their legs for them in hopes
Wow.
of regaining some movement. Very
That's
unique. My last one was in the hospital, which actually led me to want to work in a hospital coming out of grad school.
wow. You've had such a unique first several years of your career. I've just been in office settings, which I enjoy. I can't do a medical setting, but it's really interesting to hear about secondhand for sure. So what was the hospital setting like?
So I worked both in my clinical as well as my first job out of school was in a community-based hospital. The first hospital I was in was a 90-bed hospital. The first one that I worked in post grad school was 199 beds, I believe. So definitely on the smaller side. We're not talking a Brigham and Women's, Mass General, anything like that, which have hundreds, probably closer to 500 beds. So we're talking not even half. What made that experience so unique and felt like home to me was that you are working so closely with all the doctors, the nurses, the case managers, everyone that is coordinating the patient's care. And you're able to have one on one conversations, not on the phone or texting somebody. You can go to their office and be like, hey, I did this with Mrs. Jones, and I think they would benefit from this. You can have such a nice collaborative care that way that you don't often get in those bigger hospitals.
Great. Yeah, I guess can you tell me a little bit about that transition and what that first job was like for you?
I just actually left that job to go into home care, but it was a great experience, I will say. I had a such a supportive manager and a team of about 5 or 6 physical therapists and 3 or 4 occupational therapists, and there was also a handful of speech therapists as well, and we all shared an office and could bounce ideas and questions off of each other, and it was a nice collaborative environment because we would often go in there with a PT and OT, sometimes a speech therapist, and complete a treatment together that benefited the patient. Everyone kind of got to work on their skill set. It was a great environment to grow and for me to hone my skills to have the confidence to then go out now on my own and go into people's homes and trust that, hey, I know the signs and the symptoms that I need to look out for. That if this patient is not doing well at home, I can't just say, oh, I'll just grab the nurse, I'll grab the doctor, because I am now responsible for making sure that that patient gets the care that they need.
Yeah, so tell me a little bit more about the home care situation. If I remember right from when we talked a couple months ago, you were just starting to transition over to basically running your own business and kind of going to people's homes and working with them directly. So I guess in what situations does that happen and how's that transition been for you?
Sure. I wish I was running my own business. Unfortunately, not quite yet. So I do work for an outside company that they draw in the referrals from primary cares, from hospitals. So essentially, the patients that I was treating in the hospital, once they are leaving the hospital and go home, they might not quite be at the level that they need to be to safely return to their daily routine. And the role of home physical therapy is to try and work with them and get them back to that routine so that they can function in society. And, in the hospital, they're only there for such a short period of time because you don't want a person extending their stay in a hospital, they can only get more sick. Once they are medically clear, we want them out so that they can be in their home environment and recover, because everyone actually does recover better at home versus in an unfamiliar environment, especially when we're
Interesting.
talking about people with cognitive and developmental issues.
Interesting. I hadn't thought of that before. So if I'm understanding, it sounds like you take someone who at the hospital is on the edge of getting a lot better and kind of work with them from home to speed up that process. Generally speaking, it sounds like these patients aren't going to be lifelong patients of yours. It sounds like most of them are short term, get you better, get you back on your feet and living life again.
Correct. As part of the home care, what's required of that is the patient has to be homebound. So they can go out to the store briefly, or if they need to go to a medical appointment, things of that nature don't constitute them as an active member of the community. But once they're going out and resuming their daily activities, that's when we'd have to refer them to an outpatient clinic. Everyone hands off to the next step of the process to make sure that patient gets better.
Got it. Okay. And then what would you say a typical week looks like for you in that kind of a setup? How often are you on the road? How often are you in people's homes?
Sure. With my current company, we are responsible for seeing 30 points. So most home physical therapy companies use a point care system, and they classify each visit has a certain weight in points. A common visit for me would be worth about 1 point, while an evaluation might be worth 2 to 3 points. It all depends on the complexity of the patient. So I am given a handful of patients at the beginning of the week. I'm able to then schedule them throughout the week based on, I try and group them up geographically. So I'm not driving 30 minutes in between patients. That's kind of a wasted time. So I try and visit one town on Monday and then maybe hit the next town on Tuesday, and so on and so forth. Doesn't always work out that way because constantly throughout the week, we are getting new referrals, and some might pop in my area. And you have to do referrals as they come in. You can't say, all right, I'm in that area on Friday, it's Monday, I'm going to push that off. Doesn't quite work that way. You got to get that handled on the day that it comes in. So I might be doing a little bit driving there, but generally, I'd say I'm commuting for a little bit to get to my region, just because I'm about 30 minutes away from where I work. So that's my commute. I drive in between patients, which ranges anywhere from 5 to 20 minutes between each patient. And I'm seeing about 6 points a day, which comes out to be about five or so patients a day.
Cool. I'm curious if you have a favorite part of working in that in-home environment, and kind of, yeah, I guess it's just your favorite part of making that transition and having that new role.
Sure. Without giving any patient information away, I can say for certain that I've had a couple of experiences, even in my short time working in this sector of the field, that I've had to make judgment calls on whether somebody was stable enough to be at home safely. I did have to make the decision to call the doctor and say, this patient is in an unsafe vital range. Their heart rate is too high to be safely at home doing daily activities, and that they needed to be brought in and receive treatment. And otherwise, that patient may not have gotten the help they needed, and could have had a medical emergency as a result of what was going on.
Wow. Okay. Yeah, that makes a lot of sense. And then I remember maybe a year or two ago, we were talking about different groups of patients that you get in these different scenarios. I remember you were saying that you liked working with the elder patients because you were saying something along the lines of helping them basically regain a lot of their dignity that a lot of them feel like they weren't ever going to get back. Yeah, and just checking to see if you still feel that way, anything else pops out to you in that area.
Sure. Yeah, absolutely. I think one of the best things in a successful rehabilitation is that a patient regains their independence, which they, after going to the hospital, may have thought they lost forever. And to see the joy on their face, to even do a simple task sometimes, is just so rewarding. There was many events in the hospital that, somebody would come in with an acute stroke and they wouldn't even be able to sit up at the edge of the bed by themselves. We would be holding them up with all of our strength. And trust me, it was a workout. And within a few days, they might be walking to the bathroom. And there are times that, it will get emotional, not just for them, but for us, because we've been following them through that whole journey. And would get to we firsthand know how much it takes. We'll see their family members, and you recognize how important this isn't just a patient. This is a person. This is a human being. This is somebody's mother, grandmother, husband. They're important people in their family to.
For important people. Yeah, no, I've had two grandparents that I've watched go through the last stages of their lives. The time that I spent in the hospital with them, watching them with the nurses and physical therapists and doctors was all, like, of course, really challenging for them, but endeared me to medical staff for probably the rest of my life. It does not go unappreciated by, I'm sure, the patients and their family members. And it is great hearing you speak about that. It's clearly something that you're passionate about, and good to see you enjoying that role.
Thank you.
Yeah, I guess anything else, so the job stuff that you wanted to share that might be interesting for maybe like rising students or people just starting off their professional careers?
Sure. I think the most interesting thing in the field of physical therapy, if that's something that you want to get into, is there are so many different areas that you can work. I thought when I was first coming up through physical therapy school that I was pigeonholed to going into an outpatient clinic, working with somebody that had just had their knee replaced, and I was going to be doing these cookie cutter exercises, and that was going to be redundant my whole day long. But working in the hospital setting, a small hospital, you can work in a big hospital, you can work in people's homes, you can work in research. There is just so much opportunity to jump around and grow. And nobody blames you for wanting to switch it up. Everyone is rooting for your success in this field. And it's really amazing how much you can make lifelong connections with people in these groups, and they can help you to really further your career.
That's great. Has that been a big part of your career so far? I guess making some of those connections and bonding through work, I guess, with a lot of your coworkers.
Yeah. I was so fortunate in my first job to really gain some lifelong friends. We didn't just work with each other, but we would see each other after work. We started a fitness program that we would do once a week, and we maintained that for, I believe it was over 60 weeks straight, even through winter, snow, and rain. We hit it every single week. I think that's what's so special about the healthcare community is you can go into the floor as a physical therapist and start chatting with one of the nurses up there, one of the doctors. And at first, it may seem a little daunting, like, oh, I'm talking to this doctor. However, everyone has that same mentality, same care for their patients. So once you're able to bond over caring for a patient, it might flow into a real conversation about how their new dog is doing or things like that. And it helps you get through the day and helps you cope with some of the more challenging things that you deal with in a hospital, such as, you know, death. And I remember my first experience with it. And it was, challenging. My boss was there for me. She was like, Matt, if you need an extra day off tomorrow just to compartmentalize this, you have it. But just know that we're here for you and we will help you through it.
Incredible. That's great to hear. And then I think last question here is a bit of a fun one for you. Both of us been around Boston a long time, big Boston sports fans. Can you rank your favorite Boston sports teams for me? Maybe give me top 3 or 4.
I mean, easy. There's no question in my mind, but I'm going with one. I'm going with the Celtics. Clear
Okay.
decision. If I have to rank the rest, I think I gotta go Patriots second. I know that they had obviously a very horrible season, but I'm optimistic. Mike Vrabel's coming in. I think with the number 3 pick, we can get some talent and hopefully we can turn this around. And obviously the storied history, you gotta go Patriots in second. I think I gotta toss it out. I gotta toss it to the Red Sox. I am much less of a baseball fan than I used to be, but that was my sport when I was growing up. I remember watching games with my grandfather, my dad. I even had a brief stint to being a Yankees fan, but we don't talk about that.
Ooh.
Um,
Oh, that's spicy.
yeah, yeah, that was a dark phase in my life. But yeah, I think I'm gonna go Red Sox in third.
I thought for sure you were gonna do Patriots number 1, but I'm glad to hear it's
No,
Celtics.
I gotta go with my
Um,
C's. I gotta rock with my C's.
the Patriots are getting tough to support at the moment, I'll be
Yeah,
honest.
yeah, yeah.
I don't know if I can deal with another 3 to 4 win season.
And I just got to shout out, go Irish tonight against Ohio State. Notre Dame's going to take it home in
GG.
the national championship. My brother does attend Notre Dame right now, and I have been to 2 games myself. I think once you attend an Notre Dame tailgate, you'll recognize why I'm such a
Really?
Notre
Are
Dame
they
fan.
big tailgaters up
Big
there?
tailgaters up there. Oh yeah.
Okay. Thank you so much. I'll pause the recording here. Thank you so much, Matt. Thank you all for listening. Hope this was a good one. Please send it to a friend or family member and follow me wherever you're listening. Thanks again. Take care.